My name is Stu, clinician Tyrone Bird. Today I'm demonstrating lower extremity projections for the knee. So we're going to do 4 normal views including AP knee, medial oblique, lateral oblique, and then lateral knee. These are all done at a standing position. They can also be done recumbently, but for today's demonstration we're going to do those standing. Okay. So all the projections for the knee are going to be at 40 SID, and we're going to use a 10 by 12 image receptor. Okay, I'm going to have my patient bring the knee in. I'm going to move this back. So we're going to have them stand. We're going to internally rotate for the AP. We're going to have them internally rotate the knee about 5 degrees. For the center. Okay, and what we're going to have here for the AP knee is the central ray is going to be about a ½ inch below the apex of the patella through the center of the film space. We're going to collimate to include the bone and soft tissue structures of the knee, the distal femur and patella, as well as the proximal tibia and fibula, as well as the interspace between the tibial plateau and the femoral condyles. We're going to shield the patient, and we're going to ask the patient to don't breathe and don't move as we take this image. This is the left knee, so we would put marker on the left side of the image receptor for AP knee. Now, if we were doing this recumbently, it would be the same procedure, except we would have a tube angle of 2 to 3 degrees in order to capture the projection. Okay, next is going to be the medial oblique knee. Tape is coming off. Okay, medial oblique knee. So it's going to be the same position for the patient, except we're going to have the patient internally rotate 45 degrees. So, you can keep that leg straight, but we're going to have this one internally rotated 45 degrees. Again, it's at 40 SID, 10 by 12 image receptor. Again, this being the left leg, we're going to place the left marker. Central ray again is going to be ½ inch below the apex of the patella through the center of the film space. And we're going to collimate so that we can include both the bone and soft structures of the knee, as well as the head and neck of the fibula, as well as the proximal tibiofibular joint. We're going to shield the patient as necessary for protection from radiation. We're going to ask the patient to don't breathe and don't move. All right, next is going to be our lateral oblique knee. And in this case, we're going to have the patient rotate the knee 45 degrees externally, 40 SID on a 10 by 12 image receptor. Left leg, so we're going to have the left marker. Again, central ray is going to be about a ½ inch below the apex of the patella through the center of the film space, perpendicular with the image receptor. We're going to collimate the image to include bone and soft tissue structures of the knee, the laterally rotated femoral condyle, the patella, tibial condyles, as well as the fibular head and neck. Next is going to be the lateral knee. So in this case, we're going to have the patient go ahead and laterally turn the knee here. The knee is going to be flexed at about 20 to 30 degrees. All right. Again, it's 40 SID on a 10 by 12 image receptor. left marker here to indicate it's the left knee is affected. Now, central ray is going to be also a ½ inch below the apex of the patella through the center of the film space. However, since it's lateral, it's going to be more about perpendicular with the medial epicondyle. And we're going to collimate to include the distal femur, patella, proximal tibial and fibia, the joint space between the tibial plateau, and the inner space between the condyles and the patella. So these are your normal views for the knee standing. Again, if we're doing these in recumbent, we would have some tube tilt indicated with the recumbent position for proper projections. We're going to ask the patient to don't breathe, don't move. With all the projections, we're going to also shield the patient for protection from radiation with these images.